In the last few discussions in the various conferences, it has been discussion about GLP-1, GLP-1, GIP, retatrutide, and these so on and so forth. Now, and we know that those molecules have a good role in addressing fatty liver disease. Now we see that there is another molecule where, based upon the first phase results, they got an expedited or accelerated US FDA clearance for treatment in non-alcoholic fatty liver disease. There has been a change from the terminology non-alcoholic fatty liver disease to metabolic dysfunction associated steatotic liver disease, because of the reason that when one coins as a disease as non-alcoholic fatty liver disease, it is just a disease of exclusion, that if the patient is not taking alcohol, then it is non-alcoholic fatty liver disease. That does not point towards the fact that it is the metabolic factors which is contributing to the non-alcoholic fatty liver disease. Hence, after a lot of debate, they have reached this consensus that, considering the fact that metabolic dysfunction or metabolic syndrome can actually lead to such grave outcomes when it comes to liver, there should be a rechange of the terminology. Hence, from non-alcoholic fatty liver disease, it has been changed to metabolic dysfunction associated steatotic liver disease. And today, in the next few slides, we will be discussing about the role of thyroid hormone receptor agonist in the treatment of MASLD. So that is resmetirom, and this phase 3 trial is known as the Maestro Nash trial. Now, why does this study matter in today's time? Because we know MASH or MASLD is a progressive disease, and there was an accelerated approval based upon the Nash resolution and fibrosis improvement as surrogate endpoints in this trial. So that was a path-breaking kind of a trial where the US FDA gave an accelerated clearance for the use of this molecule in MASLD. And in this trial, they looked into the fibrosis, and we know that fibrosis is a critical predictor. It is one of the strongest predictor of mortality. Stage F3 and F4 correlates with liver-related death. Needless to say, just like the epidemic of obesity and type 2 diabetes, MASLD is also in epidemic proportion nowadays. There's an increasing prevalence of MASLD. In fact, globally, NASH affects almost 4 to 6% of the global population, with strong associations to metabolic disease. Now, why are we talking about thyroid hormone receptor beta agonist in fatty liver disease? Now, thyroid hormone receptor, that is the receptors to which T3 binds, has two types: TH receptor, thyroid hormone receptor alpha, and thyroid hormone receptor beta. Now, thyroid hormone receptor beta subtype is specific to the liver. Now, in fatty liver disease, it has been seen that there is impaired thyroid hormone receptor beta action, as a result of which there is decreased mitochondrial beta oxidation, which in turn leads to increased lipotoxicity, and which in turn accelerates fibrosis in the liver. So this dysfunction of the thyroid hormone receptor beta leads to fibrosis in the liver, and hence the role of TH hormone receptor beta agonist. Resmetirom is a liver selective thyroid hormone receptor beta agonist designed to address the metabolic dysfunction underlying NASH. The study objectives of the Maestro trial was to study the histologic improvement. So evaluate the improvement in NASH based on liver biopsies, fibrosis reduction to assess the improvement in fibrosis stage, and of course, whenever we are using a drug, we need to assess the side effects, and so the safety profile, the comprehensive safety and tolerability assessment of this molecule. Now, this was a phase 3 placebo-controlled double-blind trial, which was done in almost 245 sites across 15 countries, and there was a 1:1:1 allocation, which means that they were, in one arm, patients were given placebo. In one arm, patients were started on resmetirom 80 mg, and in the other arm, they were started on resmetirom 120 mg. So this was meant to be a 54 months long study. 54 months is almost 4.5 months 4.5 years trial. But based upon the biopsy results at week 52, they have given an accelerated clearance for the use of this drug in MASLD. Now let us see what came out in this week 52 result that led US FDA to accelerate or expedite the approval of this drug in MASLD. So this trial is still ongoing and the planned duration is 54 months. The eligibility criteria for this trial was 18 years of age or older who had at least 3 or 5 metabolic risk factors, had undergone pre-screening fibroscan within the past 3 months and with a liver stiffness measurement of 8.5, or histologic evidence of MASH with stage 1B, 2 or 3 fibrosis and an MAFLD activity score of 4 or more. They had to have a stable weight, less than 5% fluctuation in the past 3 months, and they had to be on stable doses of GLP-1 in the past 6 months before biopsy. The exclusion criteria for the Maestro trial was alcohol consumption more than 20 gram in female, more than 30 gram per day for men, HbA1c level more than 9% at screening, causes of CLD other than MASH, use of drugs like amiodarone, methotrexate, systemic oral glucocorticoids, tamoxifen, estrogen, anabolic steroids, valproic acid, and known hepatotoxins for more than 4 weeks within the last 8 weeks prior to initial screening. Patients who were having active hyperthyroidism were excluded from this trial, and also patients who had untreated clinical hypothyroidism with TSH more than 7 or TSH more than 10 without symptoms. Use of high dose vitamin E was patients were not taken, and total bilirubin of more than 1.5 times the upper limit of normal were not included in this study. Also patients who had decompensated hepatic dysfunction, esophageal varices, ascites or hepatic encephalopathy were excluded from the Maestro trial. So the biopsies were assessed centrally by 2 independent expert pathologists, and pathologists were unaware of the trial group assignments. The primary endpoint that was studied in this trial was Nash resolution with no worsening of fibrosis, and number 2, an improvement in liver fibrosis by at least 1 stage with no worsening of NAFLD activity score. The key secondary endpoint which they studied was the percentage change in baseline LDL level at week 24. Now what was the results? The results were very exciting. In the primary endpoint, resmetirom 80 mg and resmetirom 100 mg, Nash resolution with no worsening of fibrosis was achieved in 26% and 30% respectively compared to placebo 10%. Fibrosis improvement by 1 stage, that is patients who were in F3 fibrosis came down to F2, or F3 came down to F1, or F2 came down to F0, that is fibrosis improvement by more than 1 stage, more than or equal to 1 stage improvement with no worsening of NAFLD activity score was achieved in 24% of the patients who were on resmetirom 80 and 26% with resmetirom 100, which was statistically significant when compared to placebo. There was also a significant LDL reduction of almost minus 16 at week 24 with resmetirom 100 and minus 13.6 with resmetirom 80 milligram. The FibroScan CAP score was reduced. There was a reduction of minus 39.6, almost 40 score reduction in the FibroScan CAP score with resmetirom 100, and with 80 resmetirom there was a CAP score reduction of minus 41. The MRI PDFF, which was done to assess the volume of hepatic fat and the liver volume, that also showed reduction with resmetirom 80 and 100 compared to that of placebo, and this was statistically significant. There was greater volume reduction with resmetirom compared to that of placebo. In placebo, if you can see in this slide, there was no reduction in the volume, but with 80 and 100 milligram, there was a volume reduction of liver by almost minus 18 and minus 21. So this showed that amongst patients with NASH, this molecule at a dose of 80 and 100 milligram was effective in reducing the NAFLD activity score was effective in decreasing the fibrosis stage, improving the fibrosis stage. It also reduced the LDL, reduced the hepatic volume, and in MRI, it showed a reduction in the hepatic fat content. The CAP score also reduced. So both 80 and 100 milligram of resmetirom were superior to placebo with respect to the two primary histologic endpoints. Multiple non-invasive tests, including blood biomarkers and imaging, showed effects favoring resmetirom treatment. Achievement of 30% reduction in the hepatic fat content as assessed by an MRI appeared to be associated with biopsy responses as well. And adverse effects that were noticed were diarrhea and nausea, which gradually improved over a period of time. However, one of the limitations of this is that there is a lack of clinical outcome data to correlate with the histologic data, and the safety of long-term use of resmetirom has not yet been assessed. Regardless of resmetirom treatment status, the best practices in metabolic dysfunction or MASLD like diet, lifestyle, exercise should be maintained, and these effects of resmetirom were seen on above the standard of care, that is lifestyle modification. So we have one of the basic pillars of treatment of fatty liver disease being lifestyle modification, and on top of that resmetirom can go a long way to address fatty liver disease in us, in individuals, and that is how it got an expedited US FDA approval. So with that note, my presentation on Maestro Nash comes to an end.